By listening to this podcast, you agree to not use this podcast as medical advice to treat any medical condition in yourself or others, including, but not limited to, patients that you are treating. Consult your own physician for any medical issues that you may be having. This entire disclaimer also applies to any guests or contributors to the podcast. Under no circumstances shall any guests or contributors to the podcast or any employees, associates, or affiliates of the Neuroendocrine Cancer Awareness Network be responsible for damages arising from use of this podcast. Welcome, everybody, to another edition of Nets Get Real with NCAN. I'm your host, Mike Wayman, and today we have an awesome guest, Dr. Sarah White. But before we get into that, I want to thank everybody for coming that joined us in Birmingham. This coming weekend on April 5th, we will be going to Charlotte, North Carolina. It's going to be another great event, another awesome roster of doctors presenting. More information on that is at netcancerawareness.org. Go to the events page, upcoming events, and we'll have the whole rundown, how you can register, where it's at. Our next one is going to be in Minneapolis, Minnesota in June, at the end of June. So go ahead, check that out if you're in the area. We'd love to see you. This is going to be a little bit special, almost like a two-parter episode here, because today we have Dr. Sarah White, who will be joining us in a week from when we release this for a live stream Q&A. So she's going to be here twice this week, twice this month, and gonna do like a little bit of a follow-up Q&A. So welcome, Dr. White. How are you?
Thanks for having me. I appreciate the opportunity to talk to you. It's nice.
Yeah, no. Thank you for coming on. I feel like this has been a long time coming. You are, I don't know if we've explained this to you, but you are probably one of the more recent favorites at our conferences in terms of like presentations and stuff like that. I sit through a lot of them. I've been doing them for a long time, and then I was editing them, so you got to sit through them again. And you are one of the really good ones. So
thank you. I appreciate
I'm really excited to have you here. So if you don't mind, give us a little bit of background. What brought you to NETS?
Yeah, sure. So I trained at the University of Pennsylvania. I did all of my training there, all 6 years, internship, residency, and fellowship there. So UPenn is a big hub, and I was trained under the mentorship of Michael Sulin, who, as you know, is very integrated into NETS. And so I first learned of NCAN because, as do many mentees of strong mentors, he said, I'm out of town, I'm out of the country, can you fill in for me? And so obviously happy to do that. I love the metastatic neuroendocrine population. They're a very different population than we typically see on a day-to-day basis. In interventional radiology, we often see patients with liver metastasis and HCC, and NETs are very different, right? Because the longevity of patients is long, right? So most of our patients, longevity is short. And so we have to really treat them with kit gloves and make sure that we understand long-term outcomes of our procedures and are very careful. And so it's nice because we get to have longitudinal relationships with our patients much longer than we would with other patient populations. I just saw a patient last week who I'd been treating since 2012. So wonderful that she's still around and kicking and just retired from her job. And I get to see her be a grandma and enjoy life after work. So that's why I sort of got into it and why I've stayed for this long.
Oh, that's great. That's great. Now, let everybody know a little bit about what you do in terms of what field of medicine you're in.
Sure. So I'm an interventional radiologist. So if patients have oligoprogression, or if you have disease in particular sites, just one site that's progressing, or if you have liver dominant disease, so most of the tumors are in your liver, then that's times that I would step in and try to help. So systemic therapy would be given to you by the medical oncologist. Surgery, the cutting, would be done by a surgical oncologist. Radiation from the outside in would be done by a radiation oncologist. But we're sort of the specialist if there's a site that's difficult to radiate, or if you have disease in your liver, sometimes those are challenges for medical or surgical oncologists to handle, depending on how much disease or the location of the disease. And we step in and we have lots of tools in our toolbox to be able to get those things treated. One time I had a guy that had one single met in his bone, his clavicle right here. So I was able to stick a needle in there and just burn it, actually is what we do, or freeze it. And the patient now doesn't have disease anywhere in his body because he just had that single site. So we're sort of the magicians is what they call us, or the unicorns, but we're able to help with these localized spreads of cancer.
That's great. That's great. And where are you practicing now, and what brought you to Wisconsin?
Yeah, so I work at the Medical College of Wisconsin. The hospital that I work in is Froedtert Memorial Lutheran Hospital, and I was actually came out and joined this practice because it's really a amazing practice that's based in clinical care. So we don't just do procedures, and not that many of the interventionalists in the country do it anymore, but back when I was coming out, and I won't tell you how long I've been in practice because that would date me, but having a clinical practice, we have admitting privileges. So if a patient needs to be admitted overnight after a procedure, I would be your doctor that would be taking care of you. I have a clinic. I see patients once a week. And that can be, at the time that I came out, pretty unique. And so I joined this practice just based on that. And my partners are just magnificent. So good place to work. That's why I've stayed so long.
Well, yeah, and having that team around you, especially with NETS being such a multidisciplinary treatment plan, it's really important to have that support system around you. So do you do other things as well, or do you just specifically do NET?
So interventional radiologist, we do all things, right? So anything, basically I treat anything from the angle of the mandible to the toe. I once had to embolize somebody who had a bleeding toe, which was crazy. The patient had renal cell carcinoma. But so anytime a patient needs a port, so sometimes people need a port for systemic chemotherapy. If you needed that, we would put it in. Sometimes people need PICCs. So PICCs, if you would get PRRT, sometimes we put those through PICCs. We would put those in. Even somebody that has a bleeding from their GI tract and can't go to the operating room, sometimes we can fix that. We sort of the jack of all trades and do lots of different things. But my specialty among that is interventional oncology, and we focus really on cancer. And so the majority of my clinic is seeing patients that have cancer.
Yeah. Now, if seeing a new patient, what would be your first piece of advice to somebody who was just diagnosed with NET?
Yeah, I think going to a big quaternary center like Medical College of Wisconsin or anything close to where you are is really important. Getting second opinions if you don't feel like you're getting a good answer. But I think having a nice rapport, having a doctor that explains to you not only what they do, but how what they do folds into the rest of their care is really important. And making sure that, as you talked about earlier, this multidisciplinary approach to patients is really important, that they have the resources or they have that collaborative group around them that can be able to take care of metastatic neuroendocrine patients. Something as simple as putting a needle in and doing a biopsy can be catastrophic for patients that have carcinoid crisis, right? So you could have this storm where your body just takes over because of the stress of the biopsy. And if you're not at a center that can handle that, patients can have really bad outcomes. And so you just have to make sure that your doctor's well versed in metastatic neuroendocrine. You're not their first rodeo, and if they are, you are their first. That there's somebody like me mentoring them through the process, because it really is a different beast. When we talk about it, we always argue: is it a chronic illness or should we consider it a cancer? And we go back and forth of which one those should be. And you really have to have somebody that understands that you guys are patients with metastatic neuroendocrine live a really, really long time. And as I said before, do no harm first. So we want to make sure that we're treating the cancer, but also maintaining your quality of life. And you want to make sure that your doctor, that's the forefront of their mind. So I'd say just making sure all of those things are in place. And if you don't feel right, get a second opinion. I think your mom is the biggest proponent of that. Get a second opinion if you just don't feel like your doctor and you are on the same page.
Yeah, I think that's really important. And I do think that I feel like more recently in episodes with doctors that they've also said, just like you did just now, is seeing the second opinion and being able to have that open dialogue with a doctor and stuff like that. I think too many people are very intimidated in a lot of ways, and they don't want to hurt the doctor's feelings or whatever it may be. But at the end of the day, this is legitimately life and death. So hurt feelings come and go, but life does not. So what kind of advice would you give to a patient who's looking to get a second opinion, or who's afraid to approach their doctor and say, hey, I think I need to go elsewhere, aside from the standard just disappear kind of thing?
Yeah, no, I welcome second opinions. So if my patient says I'd like a second opinion, I say, okay, where do you want to go? And I actually call the doctor in advance of that so they have the information they need to counsel the patient. And so if you say I want a second opinion and your doctor gets irritated with you, I would say really think again if you're in the right place with the right doctor, because we all I like second opinions. Yeah, I'd love to hear what Riyadh Salem at Northwestern says, and I'd love to hear what Thor says at Mayo Clinic.
Sure.
And Dr. Howe in Iowa. I would love to hear their opinion because I want what's best for the patient. So if you're afraid to ask the doctor, that may be telling you that maybe you're not at the right doctor. But doctors, we don't care if you get a second opinion. It doesn't hurt my feelings. It doesn't make me feel bad. If you and I don't jive, I'm happy to send you to one of my partners. But I think you just have to realize that, as you said, this is your life and you need to be comfortable with any decision you make. I get asked a lot of times for family members, like, where should we go? And I say, this is the best center in the world. And I say, well, I want to go somewhere comfortable. And you have to remember that at the end of the day, if this is your family member that has cancer, they have to be comfortable with the decision they're making. And if they don't want a second opinion, then that's their choice. It's hard sometimes for the family members to say no. But if they feel comfortable with their doctor, that really makes them, the healthcare decision maker. And I think that's really important. So I've had many people say, I want a second opinion. I say, great, where do you want to go? These are the people, this is where I'd send you. And then at the end of the day, they say, you know what, I don't really want one after all. I'm like, okay, well, it's up to you. I'm happy to give that information. But don't be afraid to ask us. We don't get offended. And if we do get offended, then that's not the right doctor. Like I said, I welcome second opinions. I like it.
No, I think that's really great because, again, giving this directive an answer and hearing it from a doctor is really important, because I think that again, a lot of people are very very overwhelmed and intimidated by doctors and stuff. So no, that's great. Why is it so important for a NET patient to be so involved with their treatment plan? Because I know that there's a lot of people who are like, okay, well, I've been diagnosed, I have a doctor, I'm just going to follow this plan and just not question anything. Why do you think it's so important for a NET patient to be so involved?
Well, I will broaden that, and I will say I'd like all patients to be really involved and champion themselves. Sure. We see at the medical college, I do 250 liver-directed therapies. We do 250 to 300 a year. So we're seeing a large volume of patients. I say, I want you to come back in 2 weeks. Well, I have another 50 patients that I've seen between the time that I've seen you and not. So you really have to be a champion of your own care and advocate for yourself. So, as much as I'm a really good doctor, things fall through the cracks. And so that's where you all need to step in and say, this is my life. And I understand asking the good questions. Sometimes people say, well, I don't want to Google things because it makes me upset. You don't have to. I'm happy to explain things, but something's not sounding right. I love patients when they come in and they have they've Googled it. I want you to tell me about this. I want you to tell me, yeah, let's have a conversation, because it brings my level of, I can talk to them wherever they are, whether they're coming in and don't know anything or they've come in and they've Googled things. But I think being a champion of your own care is really important. And I've seen it nets and not nets, right? I mean, I had an aunt that hurt her ankle, and she just listened to her doctor, and then, couldn't walk. And finally I said, you need to go back. And she went back and she got an x-ray and it was shattered and it had to heal. I'm like,
oh my gosh,
why didn't you go back? Call, right? So I think just be a champion of yourself for any medical issue, and metastatic neuroendocrine in particular, just because you have so many symptoms and there's so many things that doctors can do to help in the healthcare industry. And nutritionists and all those things can help. And if you don't ask, we don't know that there's a problem, and so we can't help you. So I think you really have to be the champion so that you can help us help you.
Absolutely. Absolutely. Another thing that's been kind of coming to the forefront lately is mental health with in regard to, other sicknesses, specifically with us, it's NETs. What are some resources that like your facility will provide to patients in terms of like, mental health and aid in terms of mental health when it comes to their diagnosis?
So obviously there's a huge stress, right? When anybody gets diagnosed with cancer, and being able to have a champion and somebody that you can talk to, whether that's a psychologist, whether that's your medical oncologist. I mean, there's tons of resources. There's obviously, you all have done a fantastic job of outreach to patients. There's patient groups that you can talk to. There's blogs online. There's all sorts of resources for that. But again, don't be afraid to say, listen, I'm just having a really hard time with this, and what resources you have. From a medical standpoint, outside of, the psychologist, we can do things like palliative care referrals, so that you have somebody to help you with doing your power of attorney and figuring out all those advanced directives, and not necessarily that you need them at the beginning of diagnosis, but sometimes that will settle your mind. So at least you understand, if something bad should happen, this is what the ultimate will look like, and this is who I want to make my decisions, and this is what I would want at the end. And I'm not saying that anybody needs that now, but just having that peace of mind that those things are in order, so that you don't leave those things behind, or there's any question left behind your family. So having those discussions with palliative care also is excellent at helping with symptoms. So if you're just really struggling and depressed because you can't sit down because you've got a bone met and it hurts, we certainly can do things to help, either send you to radiation, or palliative care has all these tools in their toolbox to help you with pain management. So I think just making sure that, again, the more you tell us of what you need, the better we can help you, because we have resources and outreach that we can direct you to.
Yeah, I think that's really important. That again, I think it's said a little bit, but I don't think it's said enough. Is you do have to kind of get into some excruciating detail when it comes to what you're feeling with your doctor. You don't have to tell them that you're going grocery shopping later, but like when it comes to your treatment and your mental health and your well-being, I feel like if your mental health isn't in the right place, it's going to be harder for an interventional radiologist to help you, because you're already at a disadvantage, so getting in the right headspace, having the help, all that stuff, that's super important.
So I'll tell you about a very interesting study that was done by Jennifer Timmel in the late 2000s. So she's a palliative care doctor at Mass General, and she published a study, and she looked at patients that had lung cancer. And so their overall survival was about 9 months at the time, given the chemotherapy regimens and radiation treatments that we had. And she looked at integrating palliative care, so talking about death and dying, having those discussions I talked about, symptom management. And what she found is that patients that were randomized, so both got the same chemotherapy, treatment, surgery, all of that. The only difference was that half of the group got palliative care consultation, and those discussions happened, and half didn't, and those patients lived 3 months longer. So that to me is so impactful, about how having those discussions and being open, as you've just talked about, being open with your feelings and open with your doctors really does improve survival. So sure. I talk about it all the time with my patients, and they're like, oh, Dr. White, really? And I'm like, no, we are going to talk about this because it's so important. And if it improves your life, and sometimes that amount of time, 3 months in the cancer world, is huge amount of time to live longer. Some drugs don't even last 3 months longer, and they're FDA approved for giving for chemotherapies, right? So if sure. just having those discussions improve your overall survival, I think everyone should engage in them, right?
Yeah, I think it's crazy that people don't understand the impact that stress has on your body. Yep. And yeah, absolutely. So with regard to getting proper care for a NET patient, what do you think is the most important decision they can make?
Oh, that's a good one. I think probably making sure that you have been seen at a big academic center that does nets is the most important thing. Now, you don't have to get your chemo if it's chemo. You don't have to get your day-to-day care at a big center, but at least having either a second opinion or a first opinion at one of those big centers, I think that's probably the critical piece, because you want to make sure that the most advanced care is being delivered to you, and making sure that you're at a center if you do undergo any procedure. And like I said, even a biopsy is a procedure, a paracentesis, so a needle in your belly to suck off some fluid. All of those constitute procedures are done at centers that can adequately manage if you should go into a crisis, because you don't want to have a bad outcome because you went to some place that doesn't understand how to manage patients like you. So any like those things, you got to step it up and go to a big center. The day-to-day stuff you could see locally, but making sure that you're sort of in touch with a big academic center that handles this type of patient on a daily basis.
Yeah, absolutely. Absolutely. So before we head out here, I do want to thank you for joining us and hanging out and giving us a little bit of insight. To anybody who is listening to this or watching this on the NCAN YouTube channel, Dr. White will be back with us on April 9th at 7 p.m. Eastern. I believe that's what it is. Yes, 7 p.m. Eastern, 6 p.m. Central, for a live stream Q&A. She's going to be here live, and you're going to be able to ask questions directly to her in real time on the NCAN YouTube channel. Again, that's April 9th at 7 p.m. Eastern, 6 p.m. Central, or it'll be 4 p.m. Pacific. So please come back for that if you have any questions. If you have any questions regarding this podcast or just in general, interventional radiology is a really, really interesting and in-depth topic. And once again, being part of so many of these conferences and stuff, I've seen a lot of them. I've seen a lot of presentations and stuff like that. Dr. White's presentations are engaging, they are entertaining, and super informative, because again, interventional radiology is not easy to make fun, but you do a great job keeping people engaged. So I'm really excited that you did this today and that you're going to come back with us. Go ahead into the YouTube channel, the NCAN YouTube channel, and look up Dr. Sarah White, because she has several videos up there, and they're all really great. So get primed and get ready, and come back on the 9th. And Dr. White, thank you again for doing this.
Thanks. I appreciate the time. And any questions, I'm always happy to answer from any patients or anybody, really, right?
No, we appreciate
family,
it.
friends, anybody. Yeah.
Yeah, absolutely. We really appreciate it. And yeah, everybody come back and hang out with us on April 9th. And we'll see you next time on Nets Get Real.